In 30 seconds, we will be live.
You know when to start.
Yes, we are live now.
Very warm welcome to all the esteemed faculty members and the delegates to this 26th episode of the Public Awareness Committee with the West Zone Societies. Today we are celebrating the World Population Day, and to increase our awareness, today's program is focused on topics of contraception, unmet needs, tribal ligation, as well as we have an extremely important panel discussion highlighting the cafeteria approach of contraception. With this, we seek blessings of Lord Almighty to begin with the webinar first. Can we have the inauguration slide? Thank you, Abhishek. We're all delighted that we have the chairperson, very own Dr. Priyanka Vivek, who is celebrating his birthday today to address the gathering today. He is chairperson of the Public Awareness Committee for the current tenure as well as the president of Water. Dr. Priyanka, we welcome you to address this gathering and to introduce our guest of honor today, Dr. Madhuri.
Thank you so much, Monica. It's indeed a pleasure for me to be with all of you again today for the 26th time. And this webinar series of the Public Awareness Committee has been going on for the last almost 2 years now. And we are very happy. And I mean, I would say I'm delighted today, not only because this webinar has crossed the Silver Jubilee or the 25th episode, but we are also going to release the our first episode of our PSC Times, that is an academic newsletter of the Public Awareness Committee. I'm also delighted, thanks to the Fogsi office bearers, Madhuri Patel ma'am, who was there in person in Mumbai in the last Sunday when we had done the 75th episode of our very popular Preserve the Uterus program that we have done physical programs, and it was in Mumbai. And I thank all of you for your blessings and your continuous support for the same as well. So today, to begin with, I cannot, of course, start without thanking our President, Dr. Jaideep Tang sir, our Secretary General, Dr. Madhuri Patel ma'am, our Vice President, Dr. Ajay Mane sir, and of course, my elder brother, Dr. Kalyan Barmade, for extending the support for this program. My immense thanks to Dr. Monica, Dr. Shatabdi, Dr. Madhumita, who have put in excellent efforts towards these programs all through, and thank you for being the coordinators for most of our programs. Our conveners, Dr. Vaidey ma'am and Dr. Monica Gupta ma'am, who are our West Zone coordinators as well. I thank both of you for your extended support and continuous efforts towards PSC activities. Our chief guest today, Dr. Jaideep Tang sir, he probably will join a little late. He's stuck up in another webinar. I would like to really welcome our guest of honors, Madhuri Patel ma'am and Anju Soni ma'am, who have taken out time of a busy schedule to be with us today. We have two excellent talks by Dr. Monica Singh and Dr. Ashish Kale. We'll be talking on updates in tubal ligation, and Ashish will talk on contraception, unmet needs. Today being the World Population Day as well. So it's a day where we talk about contraception as, of course, the primary goal of India. I think one of the important motives or thing of India today should be because we are the most populous country in the world currently. I welcome the chairpersons, Dr. Bajrang sir, Dr. Vaidey ma'am, Dr. Archana ma'am, and Dr. Brajwala ma'am for the same. Our panel discussion, there will be an excellent panel, I'm sure, moderated by Dr. Manish Pandya sir and Dr. Jaju. Thank you. Monica, Dr. Sastri, Dr. Sanju Agarwal, Dr. Zara, Dr. Prajna, and Dr. Surya Kulkarni. So welcome all of you, and it's indeed a pleasure now for me. Well, see Dr. Ma Patel, ma'am. Can I have ma'am speak, please? Madhuri ma'am, all the EG for Jogian Journal of Obstetrics and Gynecology. She
I think he's lost connection. Dr. Madhuri Madam is currently the Secretary General Fogsi and the Joint Secretary of Fogsi in 2009. She has been an active committee member of EGO preterm birth. She's also the Associate Editor General of Yogi, an honorary clinical associate at Nauroji Wadia Hospital and a consultant counsel at Police Hospital, Mumbai. Madam has been ever encouraging through all the programs of the Public Awareness Committee. Ma'am, your presence has always given us strength to carry forward such academic events. For your blessings, ma'am.
Uh,
Thank you, Monica.
Thank
But just one thing, ma'am, before you start, she is currently the editor-in-chief of our Jogi Journal. And ma'am, thank you so
Yes,
much for being there, for extending your support for all our programs. And thank you for being there physically as well for the last program that we did on Sunday, in spite of your travels from Surat. So thank you so much, ma'am, for joining today as well. We look
uh,
forward for hearing from you for your
कि आज
blessings.
शम्मी में लोग घर पे बैठ के थोड़ा डिस्कस करके फिर कल फाइनल करते हैं थोड़ा सा कम में
can everybody
नहीं
mute
आपको
themselves? Everybody can mute?
yes, ma'am.
Yes. I must say Priyanku made all of us run, for his 75th, program, CME in Mumbai, from Surat. Dr. Jaideep, myself, Dr. Suvarna, Dr. Niranjan, Dr. Geeta, Dr. Komali made everybody run. He's so popular, with all of us. And, he is really hardworking, dedicated, and, I'm so happy that he's doing 26, this webinar of the public awareness. And there he did a 75th, CME on preserve the uterus. So, and practically he's there everywhere. Though Monica, he's looking after all his webinar and everything, but he is there everywhere in the CME physically or digitally. So with this, our respected Dr. Jaideep Chang, today's chief guest, then Dr. Ajay Mane, Vice President Foxy, Dr. Parikshit, Dr. Priyankur, excellent chairperson, Dr. Kalyan Baramde. He has really worked hard during his chairperson post for preserve the uterus, that theme. Then convener Dr. Vaidehi Marathe, Dr. Monica Gupta, then guest of honor Dr. Anju Soni, coordinator Dr. Monica, and Dr. Shatabdi. I think there is something somewhere, with M, Monica, three Monica today and M Madhuri today, there is something, relation is there. So he always calls, all M, people together. So I'm really happy that I am one of the person with related to M. Then, of course, we have then Dr. Monica Singh and Dr. Shatabdi as a coordinator and another Monica as a coordinator, then Dr. Bajran, Dr. Archana Trivedi, Dr. Ashish Kale, Dr. Brish Bella, Dr. Manish Pandya, Dr. Rachna. Then we have Dr. Madhumita, Dr. Sejal, Dr. Megha, Dr. Sanju, Dr. Jalak, Dr. Prema, Dr. Pragna, Dr. Prajakta, Dr. Sujata. And if I have forgotten anybody, please excuse me. And all dear friends, very good evening to all of you. And, as a Secretary General, it is always my privilege to address all of you. And it is really great honor to me. And now we are 276 member bodies and we are 44,000 committed members for the women's health. And I must say today on this World Population Day, we are, observing this World Population Day to make the people aware that there is explosion of the population. If the population grows more and more, then we all are going to face environmental problem, economic problem, and the health problem. And as all of us are aware that we have surpassed China. And we have to have, fertility rate to reduce. Of course, our fertility rate has reduced. I mean, they achieved the goal in last year as 2.1 by 31 states, and 5 states have not achieved. We are working on them, but we have to work overall to achieve that, fertility rate remains in that, goal. But now let me say that how contraception plays, because there is 40% is the unmet need of the patient who don't desire pregnancy, still they conceive. So contraception, we have baskets of contraception. We can give choices to our patient, and definitely we can avoid the pregnancy, unwanted pregnancy. Otherwise, usually they'll end up with the abortion many times unsafe abortion, and also high maternal and maternal morbidity and mortality. So I must say that this World Population Day is started by, Dr. K.C. Jaharia, who was that time World Bank, senior demographer. In 1985, he realized that, there is a 5 billion population, and if you don't control, we are going to face lots of problems. And then United Nations has started observing this day on 11 July from 1989. So we are really with that, and we have to say that we have to control our population. It is not like that, because last generation, when my generation, I mean, my two children, 1 to 2 children are, my generation. Now there are many couples, they don't want to have child, but that is not the, solution. My parents' time, there were three, four brothers and sisters. Before that generation, there were 7, 8, 12, siblings. So now as the women are getting educated, we are improving on this aspect also. And of course, the marriage below 18 has also been very, very rare. Only 27% are occurring. So this is also one of the factors which we are going to achieve our target. So these public awareness, programs are very good. And, as I was talking to Monica, she said every month, according to month-wise, we arrange the public awareness program. Last month, she had infertility, month. So they have arranged those webinars for the public awareness. This time, they are arranging for contraception. So that is the excellent work they are doing. And I'm very happy they are going to come out with news times, about the infertility. And it is really hard work. All of you are working so much hard that without that, looking after your family, looking after your practice, and looking after this webinar and the newsletter and the physical semi, it is very, very demanding. So I congratulate all of you for your hard work. At the same time, I congratulate you for this webinar, physical as well as the online, and I wish you all the best. And I'm really happy that I'm here, and I'm really, thankful to all of you for inviting me as a guest of honor over here. Thank you once again, Priyankur and Monica.
Thank you so much, ma'am. It's indeed a pleasure for us that you are here today with us. Ma'am, we would request you to stay on for a little more time till we release the PSC times, ma'am.
Sure.
So if you could just stay on for Thank you so much, ma'am. Anjuswani ma'am is with us. I think she has not joined yet, right?
I cannot get through her. I think she must be in an emergency.
No problem. Once she joins, we'll take her. No problem. Once she joins, we'll take her message. So, Monica, we can go ahead to the release of the PSC times.
I would like you to brief everybody about what is your idea about PSC times, and then I would also like Dr. Madhumita to speak about what were her experiences regarding this issue, so that we can release it in the presence of Dr. Madhumita.
Thank you so much,
Monica.
Monica.
Yeah, Dr. Madhumita, just one line I would like to say. I mean, it was just, before a week that we decided that we are going to come out with this PSC times, and Dr. Madhumita has really put in enormous efforts in getting everything aligned, getting all the text from all the webinars that we have done. So basically, the basic concept was that all the webinars that we have done, we got the talks from experts, stalwarts, and we got a paragraph done of all the talks so that we could have it in a text formats which could be circulated, which could be beneficial for everyone, because we know that how much pain everyone takes to make their PPTs, so that in a text format becomes so much very easy when it's done in a summary format. So Dr. Madhumita, thank you so much for putting in so much efforts for doing the whole thing. Now we'd like to hand over to you only because you have put in all the effort. I think you should speak about it, and you will be the best person to talk and brief us about the same. Thank you so much.
Thank you so much, Dr. Priyankur, for having the trust in me that I'll finish it in a week, and also the opportunity also. And actually, while going through this, I learned a lot also. Like, we think that once we listen to the webinars, then actually it is, and summarizing this is a great idea, because like sometimes they're not able to look upon text after text. So this 500 to 600 words of summary of each topic, really, I hope it's useful for everyone. And also, we've also compiled the work of the PAC committee, and which is huge, like really enormous, what both the webinars and the physical CMEs and other social work. So everything is compiled here. So I hope it's an interesting read for everyone. Thank you so much. Thank you so much, Dr. Monica, for all the support. Over to you.
Abhishek, can we have the PAC times on the screen for everybody to see? Uh, can we change the pages? This is the first page. This edition also covers all the competitions that we have organized in the last 2 months and their results. And it also highlights the Tejasvi project, which is an ambitious project of the Public Awareness Committee, which is on osteoporosis. We are doing the bone marrow density of various patients all across India. And we will be thankful for Torrent to join hands with us for this initiative.
They've also selected of the we have done, and some of you as well over here. This was the app that we had created, and the app is also doing quite very well, which was regarding the awareness towards women. This is the BMD camp that we. The next place, please. No, keep going at the back. Come to Tejasvi, please. So we have a page on Tejasvi with BMD. We have been doing. It's been doing quite well. Like this is the 75th program of the. And we are also launched a new project with our academic partners with Corona Remedies, where they are going to do something called a ANC Care, where they're going to circulate booklets to women for giving them good information about the first trimester, second trimester, and third trimester care as well. So thank you so much once again. I hope this booklet will be useful to you. We request you to circulate it as much as possible. Thank you to all of you. And Dr. Madhumita, your final words, and then we go on to the scientific. Thank you so much.
Yeah. Thank you so much, Dr. Roy, for all the support and for giving me this opportunity. So we'll go on to the next thing.
So now let me congratulate, since it has been released in my presence. So I congratulate Dr. Priyanku, Dr. Madhumita, Dr. Monica, and entire team who have really worked hard to come out with the PAC times. And it is definitely going to be useful because you have compiled everything what you had done in webinar. And it is, anything, as I also said in my, your last word, like a Benjamin Franklin quote, that investment in knowledge gives the best interest. So whatever you invest, whatever you read, whatever you hear, you are definitely investing in your knowledge, and this is giving best to treat our patients. So again, once again, congratulations to all of you, and keep on working, keep on doing best what you can. And on a lighter note, I will say that on a lighter note, I will say, if anybody wants any sponsorship, please contact Priyanku.
No, ma'am.
Did you
I'm
hear,
finding it
Priyanku?
difficult to get
Did you
sponsorship
hear
on a
that,
conference
Priyanku?
itself. I heard, ma'am. I heard that, ma'am. I'm finding it difficult for my conference itself. But then, yes, ma'am, thank you so much. And I'm for being there. And thank you so much for allowing us to release it in your presence. Thank you.
Thank you so much, ma'am, for your blessings, ma'am. Thank you, ma'am.
Thank you, Dr. Madhumita, and thank you, Madhuri ma'am, for gracing this occasion. Thank you, Dr. Priyanka, Dr. Madhuri ma'am, for gracing this occasion. And we now move forward to the academic session. The first talk is by none other than Dr. Monica Singh, madam, and I would like to introduce our chairpersons for today's session. Dr. Bajran sir is a professor and head of the department at Government Medical College, Sitar, and he is a former principal medical officer and laparoscopic surgeon and guardian at ANSBI, Sitar. We welcome you, sir. Our next chairperson is Dr. Arjuna Dwivedi, madam. She is the national chairperson of the IMS website committee. She is the president of the Baroda Obituary Society and the founder of the NSW 1920. She is also the secretary of the Women's Doctors Wing for IMA and practicing since last 20 years in Vadodara. We welcome you, ma'am. She has many accolades to her credit. I would request Bajrang sir to please introduce us to the
I hope sir is doing that. Hello, sir is there. I think.
Yes.
Dr.
Monica
sir, go
Singh.
ahead.
I have to tell about Dr. Monica Singh. Is Dr. Monica
Yes,
Singh
yes,
is
ma'am.
MD, DNB Uh, FMS, FICOG, CMP, and she's consultant reproductive medicine, Bhopal Fertility and Endoscopic Center, Professor Allen Medical College, Bhopal. Managing Committee member of ISR, West Zone Coordinator Medical Disorder Committee member, and Post Coordinator, Fogsi Infertility Committee, and Sexual Medicine Committee, Organizing Secretary, 27th Annual ISR Conference, Bhopal.
Thank you, sir. Thank
And
you,
Madam
sir.
has so many.
Thank you, sir. Thank you
Thank
for the
you.
introduction. Thank you. Thank you. Thank you, chairpersons. And can I speak now? So at the outset, I would really like to thank my dear friend, Dr. Monica Umbadan, for extending this invitation. And I really asked her, because being an infertility person, do you really want me to speak on tubal ligation? But she said she has confidence that I'll do a good job. And it has been a great reading and learning for me, and revisiting all the knowledge of current scenario and the government programs and everything. So I am grateful to Priyankur, who is chairperson PAC committee, doing a great job. Congratulations on the release of PAC Times. Congratulations to Dr. Madhumita and Dr. Monica Umbadan and the whole team. And I would also like to thank our respected President Fogsi, Dr. Jaideep Tang sir, Secretary General Dr. Madhuri Patel ma'am, VP Dr. Ajay Mane sir, and of course, Dr. Kalyan Barmade, the previous chairperson. I would like to thank my chairpersons for chairing our session, and I've just start sharing my screen now. So this talk of mine will be dealing with tubal ligation and how it has been revisited in the recent times. This is sometimes we just ignore this topic. We are not very interested in this topic, but the history is very interesting. The topic, of course, is fantastic. And in the next 20-25 minutes, I'll be dealing with the background of my talk would be given, along with the recent statistics, the methods of tubal ligation, and of course, we'll touch on the medical legal aspects also. So this is a busy slide, but I would really wanted to emphasize that overpopulation in India has always been concern to our government right from the time we got independence. And 5 years after independence, India actually became a trailblazer in the world, because it was one of the first countries and democracies to launch a nationwide family planning program, the primary intention of which was to control the rapidly increasing population. However, in 1966, because of the low level of education in couples in India, the method acceptance shifted towards the permanent methods. In the beginning, the focus was on male sterilization because there was an urgent need to stabilize the growing population, and there was extensive poverty all over India. However, after the emergency that, unfortunate incidences we had in a particular government in early 1980s, the program started adopting new agendas of voluntary acceptance of family planning. And the focus shifted from male to female sterilization. Since then, female sterilization has been dominant in India, and more so in India than in any other country of the world. So female sterilization continued to be the most accessed method of family planning, and it is still today. Now, the statistics say that almost 37% women in India between the ages of 15 and 50 are sterilized. And this sterilization is usually in very young women between 20 and 35 years of age, probably because these women are getting married very early. We have a survey conducted by the Government of India known as the National Family Health Survey, or NFHS. So it started with NFHS 1, 2, and now we are on NFHS 4, soon to conduct NFHS 5. This reveals that sadly, that 1 in every 3 women who are sterilized, however, they regret that they were not informed it's a permanent method. So this is the sad part of the story, that these women are taken for sterilization. They are in hundreds and thousands of sterilization operations are done, but 1/3 of them are not aware that it is even a permanent method. Sometimes it might be a woman as young as 28 and she gets sterilized. So 68%, that is 2 out of every 3 women reported that they are not even informed about the side effects. So I'm not criticizing the government program. I'm saying that at least, have a communication with these patients, because these women are married early, they have early childbearing. So when they get sterilized at a very young age, it is usually associated with sterilization regret, particularly in those women where there's pressure for a male offspring and there is an early child loss. Male sterilization accounts for only 3.3% of the NFHS 1 data. And after this, this has steadily declined. So from 3.3% male sterilization, we have gone to 1.6, 1.05, and now 0.3%. So male sterilization is decreasing, which should be actually the easy part of the whole sterilization program. And whenever there is in a government or in a country, there is excessive dependency on female sterilization, it actually debases the women's progress, the women's educational status, that this set of women of this country do not know the utility and the method of use of modern methods of contraception, which are safe and reversible. The reason for emphasizing the use of modern reversible methods of contraception is because it is closely associated with positive outcomes of women's health, and it is an indirect indicator of women's social well-being. So this, I wanted to, stress on it very much, that in a country where the reversible methods of sterilization, that is the bar in red over here, are not used, this actually signifies that these women are not informed, they are not educated enough, and they are still banking on female sterilization to combat poverty and to combat their growing families. So this bar chart shows there is decrement in the percentage share of women being sterilized. See, the sterilization is decreasing, but still 3/5 of the women still use it as the primary method of birth control. And there is a slight increase in modern methods of contraception, because very many of our women are now studying, getting educated, staying unmarried for a long time. So the modern methods are increasing in utility, but not as much as the West, and we have a long way to go. Now, the green bar over there is traditional methods. And traditional methods are, they have the same percentage over the last 50 or 60 years. There is no change. So this diagram tells you how socio-demographic characteristics and fertility-related characteristics and the media awareness regarding family planning influences the type of contraceptive method that the woman uses, which may be female sterilization, which may be a modern reversible method, which may be a traditional method. And you can see the survey years. So there has been a survey regularly. NFHS 1 conducted in 92 to 93, NFHS 2, 98 to 99, 3, 2005 to 2006, 4 in 15, 16. So there will be another survey very soon. So we have seen, and I read about it, that the more poor the family is, the more low is the socioeconomic status, and the poorer is the wealth index, and the rural population, less educated women, they will be more, not coerced actually, but they will be more inclined to use tubal ligation as a method of sterilization. That, it is just one stop method to solve all their problems. But these families and these women do not realize that if there is loss of a child, or if there is some family pressure, for example, for a male child, or if there is any other calamity or a remarriage, then this sterilization will prove very difficult to be reversed. There is also a difference in religions. It has been studied that out of the Hindu and the Muslim population, the Muslim women are less likely to use the permanent method of sterilization, because their religion does not allow so much of freedom to choose a permanent method. Whereas the poor Hindu woman of low socioeconomic status is more likely to use a permanent method of sterilization. When we see the history, we have seen that, doctors have been working, surgeons have been working on this right from 1823 to 2002, where we heard about the issue. But of course, we did not, use it very much, at least in India. Coming to the paperwork, the history is over, and history is one of my favorite topics, so I like to speak on it. But coming to the facts and coming to our clinic, we have to have the OPD case papers, documentation perfect. There has to be indoor case paper of the patient you're going to register, the proper registry, which may vary from state to state, but as such, it is uniform all over the country, a written informed consent, a separate OT register. You have to keep a certificate of sterilization ready, a follow-up schedule of the woman ready. For the routine OPD case papers, the ID proof is necessary, and there should be a separate operative procedure ready with consent, notes, follow-up, and discharge. So never ignore the paperwork. As far as eligibility and counseling is concerned, it is very important that you talk to the couple, talk to the women, that they are told that reversal of this surgery is possible, but the reversal involves a very complex surgery and success cannot be guaranteed. Because sometimes in a rural population or less educated woman, she doesn't understand the implication that what is getting a tubal ligation at the at the age of 24 or 25 mean. She can be sterilized anytime after 22. She has two children. Both the children die or they drown in the river or something. She's left with nothing. So the eligibility criteria for undergoing female sterilization, self-declaration by the client. This is the basis for compiling this information. And at the same time, having said that, no eligible client should be denied female sterilization service if she wants it. Client should be married above the age of 22. These women should be below the age of 49. They should have at least one living child above the age of 1 year, unless the sterilization is medically indicated in a woman with no children. The clients or the partners of these patients must not have undergone sterilization in the past, but this doesn't apply if there is a case of sterilization failure. And as I'll be speaking subsequently, sterilization failure also carries a hefty, remuneration has to be paid to the couple by the government. The clients in the consent form should have a sound state of mind. They should understand the full implications of this almost permanent procedure. If it's mentally ill patient brought by her mother-in-law or something, she should be certified by a psychiatrist, and statement should be given by the legal guardian or spouse regarding soundness of mind. Of course, you need a relevant medical physical examination, laboratory investigations to ascertain the eligibility for surgery. So counseling should also be done, that there is a redressal mechanism available in the form of an indemnity coverage in government programs of sterilization. In private hospitals also you apply for it. There should be a method-specific counseling, like we deal with infertility. During counseling for sterilization also, use simplified schematic diagrams. You can use, audiovisual aids to explain to the couple what they'll be going through. And they should be counseled in the language they can understand, they are comfortable with. Clients should be informed of all the available other methods of family planning also. Sometimes they must not be knowing even that there is something called a long-acting IUCD, or there are small tiny pills she can take for years and years without any side effects. She should be made to understand what can happen before, during, after surgery. What are the side effects, potential complications? And after they have been explained this, they have to be told it's a permanent procedure. It's a surgical procedure associated with even failure. Moreover, some have got the, that thing in my mind, some couples, especially the males, that it does not affect their physical sexual pleasure. They can perform normal day-to-day functions, especially in the case of males. But however, sterilization will not protect against RTIs, STIs, HIV, AIDS. So for that, protection is required. Reversal is possible, but cannot be guaranteed. And moreover, most important thing is consent of the husband or partner is not required for the woman to get sterilized. But whenever you do this operation, the partner should be encouraged to come for counseling. What happens if the patient is HIV positive? No woman should be denied female sterilization just based on the HIV status. And women who are living with HIV or have AIDS on an antiviral retroviral therapy can safely undergo female sterilization using universal precautions. And these women have to be counseled that in addition to undergoing female sterilization, they have to continue using barrier methods to help prevent transmission of HIV to the partner or husband. And no woman should be coerced or pressurized into having sterilization, including the women having HIV. So I've already talked about the informed consent and how to document it. So if it's an uneducated patient who is not literate, she can put her thumb impression on the informed consent form for legal authorization. And the client must always sign or put a thumb impression on the consent form in the presence of a witness. And this witness cannot be any person associated with the service facility or clinic and should not be a person who's chosen just by the client. And it should not be obtained with any physical or emotional pressure or force. A client who's unfit for sterilization should also be counseled and not, just sent away. The couple or the woman should be offered another suitable method of contraception. You should explain the denial of sterilization and document it in the prescribed consent form. So there are certain conditions where there is no medical reason to deny sterilization and you accept the case, that is category A. Category C is where you exercise caution, like you do not conduct it in a routine setting, but with extra preparation and precautions in your OT or in your clinic. Delayed, the procedure is delayed. The alphabet D stands for until the condition is evaluated, you delay the procedure and you correct the condition. And in the meantime, you use alternative temporary methods of contraception, the best methods available. And S means special conditions where the procedure can only be performed by experienced surgeon and staff with settings where equipment for providing GA and backup medical support is available. And most appropriate anesthesia regime is used for these special cases. Coming to anesthesia, usually we do it in local and analgesia, just local with analgesia, but there are some special cases where you may have to use, full general anesthesia or total intravenous anesthesia. Here you have to document the time of anesthetizing the patient, the drug use, dosage, route, and of course, documented by the anesthetist. We all know what is the timing of tubal ligation operations. It could be post-abortion. It could be postpartum. Postpartum is 24 hours from delivery up to 7 days. And laparoscopic tubal ligation, though easy, should not be done after second trimester MTP or postpartum immediately. So this table tells you that the uterine size is normal in interval and almost small in post-abortion, enlarged in postpartum. So naturally, the surgical incision site is suprapubic in the cases of interval TL and post-abortion TL, but it is subumbilical in the case of postpartum. And you can schedule the interval sterilization at any time that pregnancy can be ruled out, ideally within the first 2 weeks of the menstrual cycle. And post-abortion TL is usually done in the first 6 hours after uterine evacuation and postpartum within 7 days of delivery. The incision types are described here. Mini-lap tubectomy is performed using 2 types of incisions. The subumbilical approach you can see when it's a bulky uterus just extending up to the umbilicus or slightly above. 7 days after delivery, it goes subumbilical, and suprapubic approach for the interval TLs. There are so many techniques available with us, like the fimbrial ring, fimbriectomy, hysteroscopic microinserts, Assure, which never became very popular in India. Techniques is Pomeroy's, modified Pomeroy's, I think all over in government hospitals is the most popular technique, though it wastes a long length of the tube. Then there's Parkland, Uchida, Irving, band ligation with laparoscopy, clip occlusion devices, electrocoagulation, which is becoming very popular, mini lap, LCS, and vaginal methods of TL were also taught, but they are not very popular nowadays. So just to talk about the modified Pomeroy, because this is the most commonly used because of the lower failure rate associated with it. So the most important thing we remember from our PG days is you raise the mid-isthmic portion of the tube, folded at the midpoint. Use absorbable suture only. And the fundamental thing is that these sutures, it gets absorbed and both the ends are sealed and they move away from each other. And that is the reason the failure rate of modified Pomeroy's is so less. So this is how the, pimpectomy is done. That is how the modified Pomeroy's is done. That's a band clamp. And there is a fallopian ring also. And inside the cavity, you can see a copper-containing multi-load device. So again, this is a diagrammatic representation. We all remember how we transfix the suture, tie a square knot around the proximal side, tie the distal side, and tying off the loop of the fallopian tube. But definitely when you try to do, recanalization operation with the modified Pomeroy's patient, you find it very difficult to bring the ends together. Sometimes it happens, you have to do it. The eligibility of the service providers to perform sterilization operation, you can see who are impaneled. For female mini lab sterilization and laparoscopic sterilization, it should be a postgraduate in OBGY. Specialists in other surgical fields can also do it, and MBBS who are trained in mini lab sterilization. For laparoscopic sterilization, that doctor should be trained in lab sterilization. And for male sterilization, though it's not my topic, conventional vasectomy or NSV, it could be MBBS and above who are trained in this procedure. This is a sterilization certificate for males and females, which is provided by the facility. You can see it's got, they have to mention he or she is certified to be sterile, the signature of the medical officer in charge with the name, date, and seal, and the client should acknowledge receipt on the duplicate copy before receiving the original copy. Follow-up counseling, never ignore it, because the information provided after the procedure has to be reinforced, and you have to be patient enough to listen attentively. Answer all the queries of the client, address the problems that she can experience after undergoing the procedure, to explain about the menorrhagia. You have to explain, just console her about the concerns. This helps the client cope with common problems or side effects. And always advise the client to return to the facility if there's any missed period or suspected pregnancy within 2 weeks to rule out pregnancy. This is the monetary compensation that various state governments give to the male, to the female, as well as to the facilitator. There is also compensation for mishaps. If there's failure of the sterilization operation and the woman undergoes MTP, she is entitled to 30,000 rupees. Complications is 25,000 for hospital expenditure, and so on and so forth. There is also compensation, huge amount for death and all, which ideally should never be there. So just keep moving forward. And always we should strive as gynecologists in the huge and the wonderful country which we are a part of, India, that we help build small and sweet families and do not land up with the poor, sad children, which you can see on the right side of the slide. And with this, I welcome all the faculties who are visiting Bhopal tomorrow in the peak of monsoon to visit for Fogsi Bhopal National BPCon. I know Dr. Priyankur is coming, Dr. Madhuri Patel ma'am is coming. We are having a huge show on July 12th, 13th, and 14th in the Jahanuma Palace, which is the heritage palace of the Nawab of Bhopal. I also humbly extend my request and seek your blessings for election to chairperson Foxy Parentology Committee in Foxy elections this year. Thank you very much for your attention. Good teaching is more a giving of right questions than a giving of right answers. Thank you so much.
I think perfectly said, Monica. Congratulations, and you are doing the conference so meticulously. So I wish you a grand success for that and the future endeavor also. I mean, tubal ligation is something which I think the complete contraception methods, still with the advent of emergency contraceptive and other, I would say OTC, this awareness is very, very important to do a tubal ligation in order to be safe and prevent the unwanted birth and burden to society as well as to the mother. So I think it was a very elaborate discussion. Lots of things revisited the college days, and the techniques you just showed in such a nice way. So I think the message is clear and loud that wherever the contraception completely is required, at a proper age, tubal ligation can be a good foreseen event to prevent the unwanted birth and
lady less miserable and good on health. So I think if Dr. Bajrang has to say something on that, sir is there.
Thank you, Dr. Monica Singh. You have explained such a nice word, and we came in our PG days, just like we are reading all the methods. The population control is now it is controlled because all the educated people are having only one and two child. So education is the best way to reduce the population. So we have to educate all the people. Thank you very much, Dr. Monica Singh.
Thank you.
And all the
Thank you, Bajrang sir. Thank you, Monica, and another Monica for giving us this platform. And with all the dignitaries, I also welcome Dr. Manish Pandya sir, who joined us now. And it was a great lecture, Monica. See you soon. Thank you, everybody.
Thank you, sir. Thank you,
We
sir.
can proceed to the next lecture.
Thank you. Thank you.
Thank you, Monica ma'am, for an excellent presentation. Thank you, Archana ma'am and Bajrang sir, for chairing this session. Ashish sir, can we start with the talk or?
Yes. We can start.
Yes. Okay. Okay. I now introduce the chairpersons for our next session, Dr. Vaidehi madam and Dr. Brajbala Tiwari madam. Dr. Vaidehi madam is the West Zone coordinator for Public Awareness Committee. She's the director of Mahir Maternity Nursing Home, practicing in Nagpur since last 20 years. She has a battery of awards to her credit, including the MS Signature Award twice, the Fogsi National Awards, the Sadhana Desai Prize, and the Fogsi Kritim Island Population Stabilization Prize for also. We welcome you, ma'am, as a chairperson for this session. Our next chairperson is Dr. Brajwala Tiwari, madam. She has been the past president of the Indore OBGYN Society, the vice president of Indore Menopause Society, the past vice president of IMA Indore, secretary of the ISOPAP chapter Indore. She has held various posts in various organizations. Through academician, we welcome you, ma'am, to chair this session, and I would like you to introduce Dr. Ashish Khalisa.
Thank you, Dr. Monica. Thank you so much for giving this opportunity, and good evening to one and all. So this is my humble privilege to introduce none other than very great academician, Dr. Ashish Kale sir. Although he doesn't need any introduction, well-known figure nationally, internationally, and right now Dr. Ashish is Family Welfare Committee Chairperson Fogsi 23-25, and he's having so many roles. He is Clinical Secretary ISA 22-24, Executive Member IIG 24, Secretary Pune OBGY Society 22-23, and Vice President POGS 2029. And he had been awarded so many times IIG Skill Excellence Award in 2023, ISAR Youth Icon Award in 23, B for 3 by Governor of Maharashtra. That is very prestigious.
Thank you, madam.
Award. And let me speak. You are having so many accolades. So ISAR Young Talent Award, Champion of ISAR, so many awards you are having. So it's great to have you for today's talk. So over to you, Dr. Ashish Kani sir, for your talk.
Thank you, everyone. At the outset, I'm thankful to the PSC committee along with my friend Dr. Priyankur. I wish him a happy birthday for his birthday today. Many his wishes come true, and I'm really happy to see many of my friends here, and I wish all of them to have a great journey in Foxy after their elections. And I wish them all the best. So without taking much time, today I will be talking about the contraception and unmet need. Today, being 11th of July, it's celebrated as a World Population Day, but we should not celebrate it too much, that there is something to celebrate and there is something not to celebrate. What is the things to celebrate? I should tell you that the family planning services in India has been established. We are the first country to establish the family planning services in the world in 1987. We are the country to have our own manufacturing of Saint Chroman. That is our things are. We are the country to have AI based application by the Foxy for the first time in the world to tell about what is the ideal contraception for the females, and that should be what we should celebrate upon. If we wanted to celebrate, we should celebrate our thing that the TFR, that is total fertility rate, is 2.1 in 31 states as compared to the any other countries in the world. We are going to reach to our goal of 2030 by achieving a TFR less than 2. We are the country wherein we know where to work upon as a family planning services, because 1/5 of our population now is a adolescent population, and then we must going to cater them. Today I will be talking about the contraception and unmet need. We know that there are the different contraception options. We do have diversity of the population. We do have a diversity in our population, related to the religion, related to the economics, related to their beliefs in their what do you call as a religion. So the India has a contribution to the world. We are the populous countries. We surplus the population of China in 2023, and that's why we need to talk about what is the agenda of what we can do much more about it. The agenda we should be today is talking about what is the unmet need, what is the epidemiological and statistic available methods, what is latest updates, where we stand and national family planning programs, and where we can really need to do much more work in order to achieve our goal. If we're talking about the TFR, we can know the total fertility rate by NHS 4 and 5. We are in a NFS 5, which we are celebrating today because 2.1 is an achievable goal, and we are achieved in 31 states of India. If you are compare this particular survey of National Health Survey 4 and 5, you will understood that the total unmet need is 9.9 in a 4 survey, which has come down to the 9.4. The unmet need in the spacing is for the spacing is come from 4.3 to 4, and that is a good thing as far as the India is considered. The types of contraception to be used by the married couples, if you can see, we are already work upon the female sterilization. As the previous speaker, she was talking about female sterilization. We know that this is the leading services what we are offered to our clients, but the thing is that we need to talk about more about the modern methods of contraception. We do understand in India today, we are more acceptable for the advanced method of a modern contraception methods. We acceptability to this method is 56%, and which is really a remarkable goal what we achieved as far as the India is considered. Secondly, when we are talking about the success story in our family planning programs, if you can see the urban population and rural population as compared to the IUCDs and PPIUCDs, the NFS score was more as uptake of the pills and the condom is rising. May we are not happy about the male sterilization, but there is something new which has come up, which is called as RISUG, and which will be there for years to come. And because this is a reversible contraception for the males, and that's why in the future things and in the future survey you will think that the male what you call as uptake in the family planning services is much more higher, and we are going to have increment as far as the uptake of these services by the male population. You can think of the TFR is been achieved in many of the states, but we are not happy of the TFR is not been achieved in the states like Uttar Pradesh, Bihar, and Mizoram, Manipur, wherein the problems are related to the service providers, related to the unmet needs, is because of the accessibility, because of the education, and because of the implementation of our government programs. The available methods with the latest updates, we know there are the short acting reversible contraception and the long acting reversible contraception. But if we're talking about today as a population stabilization strategies, we must focus upon the LARC methods rather than the short acting one. And coming to that, the newer things what the government of India is implicating on is the implants, and the implants are been distributed from the public sector into the 5 states, and only the private sectors. Definitely we are pushing through the Fogsi, the TOTs programs for the implants. Those who are wish to have it by the society, please contact us. We are going to reach out to you and to know how to do the implant insertion and the removals. We do understand the WHO has a tired approach for the contraceptions, but nowadays we should be talking much more about LARC rather than there are the methods which has to be used to achievable goal of unmet need. like a lamb or the pills or maybe the patches or maybe the condoms. But LARC, if we can advocate in a larger population, which will going to have good uptake and the longer acting things, which will be easier for acceptability for the adolescent population, and our population stabilization can be achievable. The Indian contribution to the family planning is from the Chaya, from the Antra, and also we have the contraception pills. Definitely, the Antra project by the UP government has a 21 of the each month. They have a Antra day. What that Antra day will do, that will going to distribute this DMPA injections on that 21st day and going to educate about the LARC methods, and that is going to get acceptability is on a more side. And nowadays, what we are going to talk about is the LARC more, because of the uptake is better from the client side, as well as the counseling. When you counsel the patients, when you counsel the young adolescent age group people, the acceptability of these longer acting devices are much more, because it's easier for them to adapt. It is easier for them not to carry along. It is easier for them to implement and sustain for this method. The 55% of the country's population is living in these states. And if you can see the India as a whole, we have a certain populations where the acceptability is much more easier, but certain states where the acceptability is little bit lower as far as the family planning services are considered. This is because of the socio-economical differences. This is because of the differences in education, differences in our, as a family planning service providers, we also have a certain things which needs to be implemented and needs to be talked about, and giving that much of time. We do understand the female contraception has a barrier methods like a female condoms, diaphragm, cervical cap, and the contraceptive sponges. We do understand there is a oral contraceptive hormones, maybe a combined pills or maybe the progesterone only pills. These are the pills which can be used for the different reasons. And that's why when you're talking about the unmet need, the unmet need, if the patient is having a menorrhagia, the same thing pills can be used for her, in order to have a spacing method, in order to have a decrease in the menstrual blood flow. And that's another method of a contraception, and we can able to implement that thing in longer run. The hormonal methods comes as a vaginal rings, maybe a dermal patches, injectable contraception like a DMP or DMPSC, intrauterine LNG devices, and the implants. The barrier methods for the male has a barrier methods which is temporary. Vasectomy is a permanent, and the in between the two, we have LARC, that is a RISU. The non-hormonal contraception for the female is we call as we should be proud of being Indian, that because it's made in India, it's called as a Chaya. It is an active ingredient of hormonomycin. The non-hormonal contraceptive, it is developed by Lucknow. It is suitable for the woman with the medical comorbidity and also in a postpartum period, and that's why it is much more uptake of the Chaya and the Antra has been increased during our COVID period. And we do understand we need to have a long-acting reversible contraception. For that, we need to advocate the implants. The implants are very much easier. Being the gynecologist, we are dealing with the much more complicated cases of gynecology and obstetrics. The implants are very easier to do the insertions as well as the removal. Only the thing is that one time you require the TOT training, and that can be provided by our committee of the Fogsi. The Resug is a new form of the LARC for the male. It is developed by the IIT Kharagpur. It is a multi-centric phase 3 trial has been done. It is a reversible inhibition of the sperm under the guidance. There is a DMSO and the SMA has to be instituted into the spermatic cord. And the patient wants to have the fertility back, you can have a dissolvent which has to be injected into the spermatic cord, and the fertility can be resumed again. And this is one of the things which will come up in our armamentarium in a few months to go. The emergency contraception, to say a few words, it is not something new. It is one of the basket approach, but it can be given to the adolescent population. You can come that the WHO has launched a self-care kit, and which has again the emergency contraception in it, which will tell you the pregnancy test is come positive, or prior to that, if the pregnancy test is negative and the patient needs to have the contraception benefits, she can adopt for this emergency contraception. The family planning programs has been launched in our country, and now it is a 360-degree holistic approach. And we have a new logo which will tell us the Zimmedari Nibha and Plan Banao. You should not have unplanned pregnancy. You should not be having unintended abortions. And that's our mission's logo, which will tell us about the 360-degree holistic approach. We do have a family planning programs which has been launched by the government of India, which is called as a national family planning programs. The policy levels, it should be like a target-free approach, a voluntary approach for the family planning methods based on the felt that needs a community, and the children is by choice and not by the chance. There is a service level which has to be looked upon about the assurity of the quality of the services. Expanding the contraceptive choices needs to be talked about. The key things for the family planning initiatives is a expansion of the basket of family planning choices. It needs to sensitization of our colleagues related to the family planning services, augmentation of the services through the ASHA workers, and the promoting the IUCD services for the PPIUCDs and the IUCDs insertions, generating the demand and the awareness about the family planning services, and is to goal to achieve a 2030 objectives, which we are talking about in a few minutes now. The ASHA workers is a key point in delivering these particular services and targeting the approaches, the home delivery contraception, home delivery of the contraceptives, ensuring the spacing of the births. The pregnancy testing kits should be given to the ASHA workers and can be allocated for appropriate using of them. And that is one of the things in order to achievable the unmet need. The mission Vikas Parivar, which has been launched by the GOI in 2016, and now it is 8 years, it's been done. 146 districts has done it to new few, because this has done a few things, is assuring the delivering of the services. Then you have to ensure about the commodity securities, building the capacity, creating the environment for the acceptability, and these are the things which needs to be talked about. We need to do unmet need to meet them, is to have campaigning related to the web page, 52 weeks long radio chat shows, toll-free help numbers, celebrity WhatsApp videos, maybe outdoor campaignings and the print and posters. To say few, we need to allocate also the logistics for the commodities to be there, because if the uptake is much more higher and commodity is not been available, it should not happen for meeting the unmet need. We do understand we need to have the now everyone is having the mobile phones in their pockets, so it is very apt to have the launch of a app which has AI, which will tell you which is the best contraception for her, and that can be launched. That is already been launched by the Fogsi in 2019, last year in 2023, and which will give us a best contraception for that age group, for that woman, for her things to go ahead. The sexual education for the adolescent and the youth, it is at most important things when you're talking about the unmet need, because these are the population of our country. 1/5 of our population is adolescent population, and once we conduct the sex educational camps into the schools and the colleges, it will increase the awareness for the uptake of the family planning services, and which then we can achieve this unmet need. To conclude my talk, from the national standpoint of view, we need to have a clear desire and need to introduce more contraception option for the general public. We need to have more researches into the need of a male contraception. We need to have access to the choice and the acceptability for the public as a general. The government and non-profit organizations need to be devote the necessary resources for long-term efficacy of the family planning in our country. We need to have one logo that's 20 आज साथ मिलकर अपने सपने सजाओ, 20 साल के बाद ही खुशखबरी सुनाओ. The thing is that we need to plan our future rather than unplanned pregnancies. Thank you for patience hearing. If there are any questions, I'm happy to have it. Thank you. Thank you, Manish.
Thank you, Ashish sir. Over to our chairperson, Brajwala madam.
Thank you so much. It was excellent talk. You have started with from unmet need, that is very, very important, and you covered all the male contraceptive, the newer contraceptive implants and their use in private sector, it is really very much required, because in government sector it is supplied, but in private sector it is still we have to start. And the myths you have covered, awareness programs and social aspect. So what a fertility person is speaking about the contraception, that is because that is the pregnancy should be by choice. So you covered everything, Dr. Ashish. It is always pleasure to hear you. So we will really wish to learn about the implant in private sector. That is the need of time. Thank you so much.
Madam, any one of you wish to have it in your societies, please let us know. We are happy to come down there and to give that.
Thank you so much. Thank you so much.
Actually, sir had come down to Jabalpur and he gave the whole presentation. So we are very grateful. And I think he's one of the nicest speakers from Foxy who has like.
Thank you, madam. It's always
So
a pleasure.
now we invite you to Indore, Dr. Ashish. Please plan for Indore webinar, like physical
Yes,
CME.
Sonapur is hardly 3 hours. Right.
Thank you so
I
much.
think Baroda also waits for you, Dr. Ashish.
And I'm really, I'm not from the Foxy point of view, but those who are contesting for the election, please go. Like it's a Zindagi na milegi dobara. Do your work. Go and appear for the elections. You will come with the flying colors. Even if you don't get disheartened, there is always a next chance in life.
Can I speak, Dr.
Thank
Monica,
you.
just for a
Thank you,
moment?
sir.
Because population
Yes,
and
ma'am.
environment plays a significant role. Increased population affects our environment, and that is causing so many health issues. So I request all of you to support me for Environmental Health Committee election this year. Thank you so much.
Thank you, Dr.
Thank
Ashish.
you, ma'am.
Well wishes.
Yes, Madhulika ma'am, you need to unmute yourself. Unmute yourself and speak, ma'am.
Am I audible?
Yes, ma'am.
My question to Dr. Ashish is, how can we get implants for our poor patients? Is it available free of cost? Sir, are you there?
Ashish said logged off, madam.
Okay.
Ma'am, he had to attend a government program as a guest of honor, so he said yes.
Never mind, I will ask them later on.
I'll share his contact details in the group, ma'am, then we can talk. Okay. Let us move forward for the next academic session. I thank Dr. Ashish Kai, sir, for an excellent presentation, and Dr. Brajbala, madam, for being the chairperson for the session. Ma'am, we wish you all the best for your Foxy endeavors. We now move forward to the panel discussion. The topic of the panel discussion is overview of contraception and cafeteria approach. Our moderators for today, Dr. Manish Pandya, sir, and Dr. Rachna Jaju. And our expert is Dr. Madhulika Agarwal, ma'am. Can we have the series, please, Abhishek? Dr. Manish Pandya, sir, is a professor and head of the department at Mahavir Hospital and Manish IVF Center, Sai Baba Ultrasound Center. He has many special awards and achievements, including the Dynamic Indian of the Millennium by KG Foundation, the Gynec Excellence Award by Foxy in 2020, a commendable editor-in-chief by ESHRF in 2021, the Icons of Gynecology in World in 2024. We welcome you, sir. The list of awards is never ending. Our next moderator is Dr. Rachna Jaju. She is currently the chairperson of the MTP and Family Welfare Committee of the Maharashtra Association of OBGYN. She is a part of the Mission Pink Health Committee, Maharashtra State, MTP Committee Foxy, the Secretary MPH Latur, the past Secretary of Latur OBGYN Society, and she has received prestigious Spurti Award at a MOX. She has been the past Secretary of IMA Women's Doctor Wing at the Latur branch also. We welcome you, Dr. Rachna. Our expert for today's panel is Dr. Madhulika Agarwal, madam. She is the president of the Jaipur Menopause Society. She has also been the secretary of the same, the vice president of the Jaipur OBGYN Society of the year 2022-23. She has presented various papers in national and international conferences, and her keen interests include ultrasound and high-risk pregnancy. We welcome you, ma'am, as an expert for the panel discussion. Today, we have many elite panelists with us who will be discussing an important topic of contraception. Our first panelists include Dr. Monica Gupta, madam. She is also the convener of this program and the West Zone coordinator of Foxy Public Awareness Committee. She is the HOD and Senior Consultant at Ducks Hospital, Alwar. She is a hysteroscopic and laparoscopic surgeon. She has been the president of the Alwar OBGYN Society and the Fogsi. She has received the Fogsi Achiever Award of the Zone Yuva Fogsi at Ranthambore. She is a Dhira Master Trainer and a Manyata Assessor. We welcome you, ma'am, as a panelist for this panel discussion. Our next panelist, Dr. Sejal Naik, is the National Coordinator of the Endoscopy Committee, Fogsi. She runs the Fogsi IIG Recognized Training Center for Gynec Endoscopy. She also has a Fogsi Young Achiever Award in 2018. She has also received the Best Paper Award at the AICOG 2019, the SOGA Star Award of 2018 to 24. She has been the organizing chairperson of UA IIG 2019 as well as the EVE IIG 2022. She has been the honorary secretary of Surat OBGYN Society, and she currently is an endoscopy and infertility specialist at Delhi and Love Women's Care, Surat. We welcome you, ma'am. Our next panelist is Dr. Megha Shastri, madam. She is a senior consultant at Krishi Khandaka Hospital, Surya Hospital, and the Cocoon Hospital, Jaipur. She is a member of the Fogsi Medical Legal Committee, the ex-member of Fogsi Public Awareness Committee. She has been a Manya assessor and trainer. She is also the RSC module trainer and the SPV vaccine champion. I'm the ex-lecturer at Rajawati Hospital, Mumbai. We welcome you, ma'am.
Thank you, ma'am.
Our next panelist is Dr. Sanju Agarwal. She is from RNT Medical College, Udaipur. She's done her DGO from Madurai Medical College. And she's a consultant at Sania Hospital, Alwar. We welcome you, Dr. Sanju. Dr. Zalab Shah is working at Rachna Women's Hospital, Patan. And she has passed her MD from Vadodara University with a gold medal. She's interested in infertility, high-risk aesthetics, and improving women's health through preventive and postpartum care. She is currently the working secretary of Patan OBGYN Society. We welcome you, Dr. Zalab. Our next panelist is Dr. Prema Nagar, madam. She's a gynec and laparoscopic surgeon and an infertility specialist, a director and consultant Mom and Me Hospital. She's also affiliated to Sarva Hospital at Vadodara, Gujarat. She has worked as a senior resident and as a consultant in various hospitals. Her special interests include holistic approach in women's health, endoscopic surgery, cosmetic gynecology, and women's health and a fitness influencer. We welcome you, Dr. Prema. Our next panelist is Dr. Pradnya Harshe, madam. She is a director of Harshe Hospital at Jabalpur. She is a consultant also at Sutika Hospital, an executive member of the Jabalpur Menopause Society and president of the Jabalpur OBGYN Society currently. She has held various posts in the Jabalpur OBGYN Society. She was also the treasurer of Fogsi West Zone Conference in 2022, and she holds special interest in high-risk pregnancy and gynecological surgeries. We welcome you, ma'am. Our next panelist is Dr. Prajakta Burude. She is a director of Mahir Hospital and Nucleus Test Tube Baby Center at Udgir. Her special interests include infertility, and she's been practicing since last 12 years. She is currently the secretary of Udgir OBGYN Society as well as the Udgir Doctors Association of Women's Wing. She is a member of AMOX Public Awareness Committee and the Sexual Health Committee. She is an organizing secretary of the upcoming AMOX Zonal Conference. We welcome you, Dr. Prajakta. Our next panelist is Dr. Sujata Kulkarni, madam. She is a consultant obstetrician and gynecologist practicing in Solapur. She is currently the vice president of Solapur OBGYN Society, and she has held various posts in Solapur OBGYN Society. Her areas of interest include female infertility, adolescent health, and public awareness. She has also been the recipient of the first late Dr. Leela Dubey Gold Medal Award. We welcome you, ma'am. I request the moderators to please take over for the panel discussion.
Thank you, Monica madam. Thank you for giving me whole cricket team because there are 10 panelists and 2 moderators. Can you see my screen? Hello?
Yes, sir.
Yes,
And
sir.
my voice is audible?
Yes, sir.
I
Well,
see that my all 10 batsmen are there. So we would like to play good T20 over here. This is my credentials. Thank you for kind words, madam. The moment child is born, mother is also born. Today is World's Population Day. So we have to salute all the mothers who had given us birth and make this world more populated. 3 books written by us is recommended in Royal College as a reading material. Atlas of Physicocardiography and Technique of IVF made easy again for 2nd edition. I am editor-in-chief of 2 journals, Indian Journal of Obstetrics and Gynecology and Open SS. Last year at Copenhagen, I got opportunity to interview Professor Herman Turne, and that all you can see on this Manish YouTube channel. I welcome all my panelists. Dr. Rachina Jaju is there?
Yes, sir, I'm there.
Yes, yes. So welcome as a moderator, and we must thank Dr. Madhulika Madam to be our expert. I'm just making this window small. Just 1 second. Arrow kya chahiye se? Hamara naam forward. Okay, let it be there. So today we are discussing this. Ashish has told Jimmedari Nibhao, plan banao. Okay. So for that, I must thank my teacher, Nitaben Yagnik, who has given me very good thing. Those who are from Civil Hospital, Ahmedabad, out of my all panelists, what you understand by GATHER, gather approach. GATHER. Those who had learned in medical college, they must know. Sejal madam, you are gathering so many people, so many webinars. Before 3 days, we are in webinars. We are gathering all the people. You must know what is gather approach. Gather approach is the ultimate approach in contraception. First, we have to greet her, ask her why Sejal madam has came to me, teach her which are the different contraceptive models available, just like Ashish sir has told. Help her to choose whatsoever she has chosen. We have to explain in detail. And most important thing in any counseling is recall. So greet her, welcome, ask her, teach her, help her, explain in detail, and recall. This should be the motto of contraception, so people can use contraception rather than saying copper is best for you, condom is best for you, implant is best for you, LARC is best for you. No. Give them the choice, and we must know. And I must welcome my MTP committee chairperson of EMOGS, Dr. Jaju. So we will start with MTP. First question, what are the investigation would you like to go before MTP? Monica, Sejal, Megha, Sanju, Jalak, Prema, Pradnya, Prajakta, and Sujata. Because I see.
Good evening, sir.
Yeah, what are the investigations? Because MTP is coming regularly.
Yeah.
And I see that people are taking MTP just like Chana Mamra. Patient is coming, you are doing MTP and patient is gone. Am I right?
Absolutely.
Nobody does like that.
Nobody does like this, madam. What do you do?
Sir,
we first of all we do transvaginal
So
sonography.
first we will take history.
no,
So first we'll take
History, of course.
medical
Investigation
history.
you ask, so
Rajal, can you give me the definition of history?
so you ask for investigation, so that's I directly jump.
Okay, which are okay, investigation, chalo. Okay, ultrasound, then you go for blood test, you go for urine test. If you and this time I must thank AI and my resident Kishan and Vaishvi. First time they had made this presentation with ChatGPT. So you can see so many things repetition, but AI can give you very good presentation. Then this is the one of the example. This presentation is totally made by AI and you say Giga. Gamma. This is the gamma. So these are the 2 things by which you can make your PowerPoint presentation wonderful, and they will give you everything.
You are always
Yes, madam.
ahead of techno, ahead, sir.
Just gamma we had used, just installed yesterday, and we had used in this presentation. And with ChatGPT, this presentation is made. So, madam, you rightly said ultrasound. With ultrasound, you would like to see for gestational age, okay? Pregnancy location, whether it's centrally, eccentrically, or cornual. You can see any abnormality in the uterus. Okay, then any blood test?
So we'll go for routine CBC to see the whether anemia is there or not.
Yes,
then
very good.
ABO-RH, blood group and RH factor. Then coagulation profile for the patient.
Okay.
And, so then we have vital markers for HIV, HPS-AG, HCV, VDRL.
Very
So
good.
these are first basic blood tests that
Basic
we'll be doing.
investigation. Basic investigation.
Yes, sir.
Sometimes we may see for urine for infection.
Urine routine. Yes, sir.
Anybody would like to go for this test?
No.
No, sir.
Sir, whenever in doubt, we should
Yeah,
do.
routinely no.
We don't do,
Routinely we
but
are not doing in India.
we can take the
Yeah.
opportunity to tell the patient that yes, these are the screening tests ideally you should undergo.
Yes, madam. Yes, madam. Then
So
how you prepare your patient for MTP?
So counseling, if we are giving medical method of treatment, then the counseling part is the most important. Otherwise also that how to take the tablets.
Okay.
So first we'll make her understand what are the pros and cons of whatever method we are going to use on her.
Yes.
Because to make her
Again the gather approach.
yes. Because first we have to make her understand what we are doing, and
Yeah.
then accordingly we have to take a consent for her, because to her to understand and then sign the consent is the main thing. And then accordingly we can go for whatever the gestational age is. Accordingly that we can go for whether we want medical or we want surgical treatment for her.
So you are preparing
sorry to
only for
interrupt,
MTP
Manish
or
sir.
post MTP?
Manish sir.
Yes, sir. Yes,
Sir,
madam.
sorry to interrupt, Archana. You should give the definition of history. That is extremely important in your words. Please do that, sir.
History is study of past in light of presence to have good future.
Wow.
Very nice.
This is the definition of history. Every day we are asking history. We are asking history in present. Patient is narrating in past, and we have to give good future. So if patient is coming to MTP, we will advise them to go for second MTP. So in counseling, we must include contraception. We must include contraception. And we also see, we have to also see that this MTP is legal and ethical, because so many times patients are coming with husband who is not husband, just a boyfriend. So how you can confirm whether they are married or not? Big question and big fallacy.
So we usually ask for the husband to come. Husband and wife.
No. If suppose he is unmarried.
Sir, only the wife person consent is important. We are not supposed to take the consent of the husband only if the patient want to whether married or unmarried. If she wants an MTP, we have to give the services, but we can explain what are the pros and cons for everything.
If patient is major, we can take consent of
Yes,
patient only.
I
Don't
must say
consent
you
her.
must see the age. If she is 16 years,
Yes.
We have to inform
then you are liable for POSCO.
So then
You have
the
to
entire
inform the
scenario
police.
changes, sir.
If patient is major, then we should not ask.
So we always have to think that the looking lady may be 20, but she may be 17, and we done MTP. Then afterwards, some police will come and then we'll narrate you. So always word of caution should be there. Whenever she comes, don't be too much generous to her and give them the service. We have
We
to
can
think
ask for
of
Aadhaar card.
because
Sir,
recently
we usually
we got
take
so many cases of POSCO running in our gynec doctors.
Yes,
Sir, when we are
usually
making
ask
the
for Aadhaar card.
admission, we are taking the Aadhaar card of that person.
Yes.
In the Aadhaar card, whatever the age is written, we take it as such.
Yes, we consider
Yes,
that
yes,
age,
yes.
whatever there is in the Aadhaar card.
So always,
According to the new law, it is not the Aadhaar card, but the school leaving certificate or the birth certificate of the patient that has to be kept as a record. Now, they usually don't
But
carry
ma'am,
that.
it's very difficult to get a birth record of
that
the
is very
birth
Certificate is very difficult.
but one thing I will tell, MTP is not an emergency. If she may go to some another place, let her go, but always be safe on your side to prove her age, because nowadays patients are making you fool. We are on a general side. Bichari ko bachcha reh gaya, hum gira dete hain. Then we are in a soup. Once you have done the things, you are the culprit. Because MTP committee, Jaju madam says, well, how much law are strict in MTP committee? Okay, so emotional support we should always give, but we have to take care very much for our patients, and follow-up should be there. So in conclusion, we have to give very much comprehensive approach. We have to go for termination, and pre-procedural cares too much. We have to take history taking, medical examination, physical examination, confirm the pregnancy, do all the tests, see for the gestational age, discuss with the patient, and always discuss contraception. Patient counseling, medical evaluation, confirmation of the pregnancy, prepare for future. Now, Rachana madam, this is your turn.
Yes, sir.
Yeah.
So now there is a patient having 9 weeks of pregnancy. She's gravida 6, para 3, living 3 with 2 abortions. And she comes with an HB of 6 gram. and she requests you for medical termination of pregnancy, that is MTP. Now, how will you go about this case? So I think we'll go with Dr. Monica Gupta, madam. How will you evaluate and proceed further?
As the patient hemoglobin is very less.
6
So
gram,
first we
madam.
have to find out what is the cause for less hemoglobin.
Okay.
As the patient has come for the MTP, we have to counsel ki if you will have a bleeding for 10 to 15 days. So your hemoglobin will fall. If you want to have an medical termination only, then you have to go for the correction of anemia before going for it. It's better you should go for a surgical intervention, because we have to tell them what is good for the patient or not.
Correction of anemia. First thing is correction of
If
anemia.
MTP is not an emergency.
We have to find out what is the cause for anemia and then correct it.
So first stabilize the anemia. It's as such it is a 6 gram. Minimum we will require, Jaju madam, is 10. Okay.
Yes. Yeah.
Minimum. Because if something's untowards happen and we had done MTP, then we are in soup.
So we need 4 units of blood. So
Yes.
we can wait for 1 week. We can give an injectable iron to the person and then we can proceed for the MTP.
So what would you prefer, a blood transfusion, that is PCV, or iron transfusion, intravenous iron?
We can give for intravenous iron also. And what is the patient choice basically? If she can wait for 1 or 2 weeks, we can give her intravenous iron because the result of FCM are very good. But if she's in the emergency, she wants it right now, we can go for the blood transfusion. But we have to explain what are the problems with everything. What are the benefits and what are the problems, what are the complications they are going to happen because of both the procedure.
Yes.
Madam,
What
according
the
to patient has got emergency, so we have to do it hurriedly.
Yeah, it is a 6 gram hemoglobin. It will require more time to improve to till 10. So preferably we'll give at least transfusion first, and then IV iron for maintenance, and followed by oral iron for the long time.
Very true, ma'am. Very true. And what investigations would you like to do for such patients?
Yeah,
Sejal,
so madam, reason for her low hemoglobin, we have to find it out. Whether she is not taking good diet, or whether her absorption is not good, or whether she is bleeding, having a rectal bleeding or something like that. Or she may be menorrhagic previously before conception. So then the iron profile we can do. Total iron binding capacity and the serum iron, etc. And B12 deficiency is also common in India, being majority are the vegetarian. So these all other reasons
any
for
role of HB electrophoresis over here?
yes. That is usually what happens, madam, when hemoglobin is very low, then the HB electrophoresis reports are really very dicey. So iron profile first, followed by correction of iron, and then if we go for the HB electrophoresis, once the patient is settled down, that can find out a reason for her low hemoglobin.
And Sejal madam, we can ask for interval MTP because those patients are coming with 6 gram of hemoglobin. We must ask that how long before you had gone for previous MTP. Just like interval delivery, we now think up to interval MTP also. Because we don't know how frequently she has gone for MTP.
Yeah.
So if she are just like 1-by-1 delivery, she can have a 1-by-1 MTP also. So we must ask what is the last MTP she has undergone. Why her HB is 6 gram? Iron deficiency may be the cause, but frequent MTP can also cause her 6 gram of hemoglobin.
Yes, sir. In this case, she already had 3 live deliveries and 2 abortions.
Yeah.
So technically, this is the 6th pregnancy.
6th pregnancy. So that's why I'm telling, na.
Yeah.
You have to see the interval MTP distance.
Yes, sir.
Now, if there is thalassemia minor trait, then even if you're giving her blood transfusion repeatedly, her HB will not be rising. So there comes the role of HB electrophoresis to rule out if she's having some traits of that sort.
Madam, in this particular case, we might not think about it because she has
not needed, sir, here, but yeah.
But routine we can go for because already she has got 3 live child, no thalassemia. So this might be the cause of frequent MTPs because to madam, this is her 6th pregnancy. Yes, madam.
So how will you counsel the patient, Dr. Megha Shastri?
Ma'am, first, like how sir said, it's a complete gather treatment has to be done here. For counseling also, we have to counsel in the same way that, she should not go first thing with the repeated abortions and repeated pregnancies. That should be the first thing. And whenever we are counseling, we should make sure that we counsel her about the contraception also, because we cannot keep having her coming to the hospital, getting pregnant, putting blood or putting IV iron. So main in counseling goes everything, sir, including the timing, because there is no emergency. So we can always hospitalize her, stabilize her, and then we can go ahead. So first we have to counsel her for the admission, then for the blood transfusion, and then the method and contraception.
So we have to counsel her that she has to wait for some time before going for MTP.
Yes, sir, madam, she has got 9 weeks of
Yes,
pregnancy.
sir.
How everybody will proceed in this particular case?
Dr. Sanju Agrawal, madam. Has madam joined?
Dr. Jalak from Patan. Dr. Prema, Dr. Pradnya, Dr. Prajakta.
Yes, sir, I would like to do in that way that I'll prepare 2 PCVs, I'll transfer 2 PCVs, then we'll do the MTP. And
It is a
after
surgical
MTP,
MTP. That is a
yes,
surgical.
surgical MTP, and then we put the patient on either IV iron or oral iron.
Okay. Anybody will disagree? Dr. Megha Sastry, Dr. Sujata.
Sir, I would like to, once her hemoglobin is built up, it's
Okay.
better we give one single tablet of mifepristone.
Okay, now HB is 10.
The medical
Raju madam and Sejal madam has given her blood transfusion. It is good, very good PCVs. Now her HB is 10. Then
medical termination, actually we can try in hospital. I mean, what we will do is we will give her mifepristone. We will wait for 1 day. Then misoprostol we can give on morning. Let's see after 4 o'clock, if she aborts, then we can just do a suction and just do a checkup, check curettage.
just uterine aspiration you can do if suppose some product of reproductive conception remains.
Yes. So we can do a combination of medical and surgical.
Thank you very much. Jaju madam, second case.
Just a second. A gravidac para 2, living 2 with history of previous LSCS. She has like preeclampsia, hypertension, and diabetes. So, how will you go about this case? I think we'll go with Dr. Prajakta this time. She is 8 weeks pregnant and just
See, this is a case of third gravida with previous to LSCS. So we would like to have the history first. And since she's having 2 cesarean sections and she's 8 weeks, so we would like to go with her surgical termination, but probably we should counsel her regarding the pros and cons for it, because she's a case of previous LSCS. There may be chances of injury. So we may explain the patient, and then we will generally we will do her examination, and we would like to have her investigations done priorly. As mentioned earlier, we'll do her hemoglobin status and everything if all the things are in routine. So I would like to do her surgical termination rather than going for medical termination.
Madam, she is diabetic, so
hypertension and diabetes both.
Okay. Yeah, then we will like to assess her status for diabetes. I'll do her HbA1c priorly to assess her status and whether she's on any oral medication or any insulin she's there. So we will control her blood sugar levels priorly. And she's known case of hypertension. We will evaluate her status and before doing this.
So again, there is
for
no need of
hypertension,
emergency.
there
We
may
should
be
control her
chances.
medical disease first, and then we will go for termination of pregnancy. As such, you have told previous 2 cesarean section, so you can go for surgical or medical method. Okay. Which method would you like, surgical or medical?
So she's diabetic and hypertension. So there may be some liver derangement or renal derangement may be possible. So we may go for surgical will be the better option rather than medical termination in this case.
Dr. Sujata?
Madam, sir, we would like to go for a medical termination. Planned. We can give mifepristone on day 1, and then day 2 or day 3 we can give 800 milligrams of misoprost. And if she does not abort till in the evening, then we can do just a suction curettage, because she's already previous 2 scar with diabetes, with hypertension. She's a high risk patient. So
everybody agrees?
Yes.
Because there are 2 things with mifepristone: anti-progesterone, second, misoprostol making uterus very contract. So chances of perforation will be very less. And second thing, misoprostol will also dilate the cervix. you give at near 12 hours time. So suction evacuation after doing this is very
Easy.
safe in our hand.
Convenient.
And as such is diabetic hypertension, where you already control the diabetes and hypertension. So after controlling this, we have to do this medical termination of pregnancy with medicine plus added needed surgically. Raju madam, your inputs.
So rightly said, we will have to make the cervix ripe because it is a previous to LSCS. We are likely to encounter a tight os. So after giving medical treatment, if we go for surgical evacuation, that will be more easier for her. Second thing to be considered here is if she is having, say, diabetes or hypertension, and she is not a person for medical abortion, the drugs may be hepatotoxic for her, then we can also think for surgical evacuation for such patients.
Otherwise, it's okay.
Otherwise, it's okay.
We have to give a prophylactic antibiotic to the patient because chances of infection in the diabetic patient are higher.
So we will give one additional prophylaxis, but now she has got previous 2 CS, both the babies are live. These are the basket of contraception. So how you advise?
So she's
Non-hormonal property.
I think Pradnya madam can answer
the
this.
procedure.
So first we have to ask about the sexual history. How many times in the month she makes the contact? Whether she is doing the contact only once in a month or many times the husband is living outside. So we will advise accordingly.
condom is
And
good.
what is the need and what is the choice of the patient? Then
Okay.
we have to give our opinion. If this will be better for you or which is better for us. We should not guide the patient कि आप copper लगवा ले या you go for the injection and all. In the last we can say कि this is better for you. In my opinion, I recommend this, and what is your choice? You can have it.
So again, we will give them the
I
basket.
think she requires a long-acting one or the longer duration, like have the protection. So
Madam,
maybe the
Sejal madam, she has got already 2 kids. Both kids are healthy.
So
It is
probably,
almost of
yeah.
7 years and 9 years. Then
So for if she asks me, my recommendation for her is to long-acting devices, intrauterine
but
device.
now
for
she
the-
doesn't want any kids. My this MTPC fed up. I have got diabetes. I have got hypertension. My husband is not listening. I am becoming pregnant and again, and then I have
It's
to
a
go.
permanent method then.
Then
Permanent
Then
method,
it will
ligation.
serve 2 purpose.
Yeah.
This will serve 2 purpose. You can do surgical MTP. You can see by laparoscopy. You laparoscopy tubal
At the same
nowadays.
set. Yeah.
So it will serve our purpose also. We are not perforating and we are doing the best thing. So for with her medical condition, I think permanent contraception
Method is
for this
better.
lady is advisable. Everybody agrees?
Yes.
Sir, sir, in the previous 2 cesarean, doing a laparoscopic sterilization is little bit difficult. It should be done only in the center. The person is very expert in doing it. You never know what you see in the abdomen. So
Madam,
better you can advise the vasectomy for the men. You
Yes.
have to go for a
That-
male,
that is the
male
best
permanent
option.
method instead of the female because the complications are less for the male than female in this case.
Madam, if we are in the era of Sanjay Gandhi, then it will be very easy to do the
Sir,
necessary. But nowadays,
but
to
we
counsel
have
a
to
male is very
counsel.
difficult. And madam, let me tell one thing that previous 2 cesarean, previous 3 cesarean, or previous 5 cesarean, laparoscopy tubal ligation is much more easier than the open tubal ligation. Sejal, do you agree?
Sir, but in rural settings, we have to like see across the country.
That should be done by expert. That should be done by expert, but more cesarean section, the laparoscopy means very easy.
Sir, I would like to add one. Sir, during
It is the era of women
availability of the
empowerment.
property to
You
her,
have to
you can counsel her.
the
I would
male
like to
partner
say
for
one thing. If
everything.
we are going for the medical
Now our
termination,
panel
then
is looking very
long-acting.
good. Everybody is speaking, so we are happy. Jaju madam, we are happy.
Sir, I
that
just
our
would like to
panel is very well.
say one thing. If we are going for the medical termination, then
Okay.
long-acting intrauterine device is going to be a better option for her, which will work for 10 years.
Yes.
So
If we are
LNG
going to
will-
medical
It will
termination,
cover her
but if we
fertile
are going
window
for
anyway. It
surgical,
will cover her fertile window.
if we are going for
what we can
surgical,
do
then
during before
permanent is a
MTP, we
better
can
option.
counsel her. Before MTP, we can counsel her that
Yes.
if we do operative, at the same time, we can put an LNG IUS or multi-load for you. And if you have an ultrasound, if you're fortunate enough to have an ultrasound in operation theater, we can be very well confirmed that yes, we have done the MTP very nicely and the device is also fixed. So we can take the
Ultrasound guided MTP.
yeah. I mean, that
Ultrasound
if you
guided MTP.
Yes.
Madam, in how many centers can you do an ultrasound guided MTP?
That is said,
When we
if you're
speak in the
fortunate enough, then only we can do.
only madam hardly one or two centers are doing it. Everybody is doing a blind MTP.
And
Very
even though there is
frankly
no
speaking.
complication till date. Otherwise, MOGS MTP committee member will come and give us liable for this. Okay, Jaju madam. So we are doing MTP, and MTP is bread and butter for so many things, and MTP is coming every day. Sarkar, that's why making MTP कायदेसर खानगी and salamat. It is safe, and now it is जिम्मेदारी निभाओ, प्लान बनाओ. लेकिन 20 के पहले बहुत सारी pregnant हो जाती है. So we have to advise them not to become pregnant. That is our motto. So as rightly said, we can go for IUD, that is copper or hormonal. We can go for implant, which is very effective. And Ashish has rightly told that if somebody wants to learn, we can come and take advice from him, and we can get government free implants. We can also go for depot. It is also 3 monthly injections. We can give them progesterone only because patient has got hypertension and diabetes. But only disadvantage of POP is that should be taken at proper time. Otherwise, there will be loss of his action. Okay, madam, every day at the night at 10 o'clock, she should take the progesterone only pills. And we can also use centromin for these patients. As madam has rightly said, his husband is working in a field and not coming regularly at home. We can give them the advantage of male condoms. Permanent method, rightly said, if it is good, patient agrees, then we can do with either open or laparoscopic tubal ligation. Other consideration, we can't give COCs because patient has got hypertension. It is both. Another case, madam, with CHD.
Sir, 1 minute.
Yes,
sir, I
madam.
want to add one point.
Yes.
Sir, we have all the time we should explain the patient about the complications also. When we are giving a DMPA injection, we should tell you can have an irregular bleeding, you can have
Irregular
an
periods,
amenorrhea.
intermenstrual
Because
bleeding,
most of the
sometimes
times when the
amenorrhea.
patient is taking POPs or whatever the things are there, we don't tell. And all the time she knows ki ek goli leni hai, and what happens if she misses the tablet? Or even though if she is taking regularly, she can have a irregular bleeding in between. So these all things we should explain. We should have some time for her to explain the complication and effects of the side effects of the drugs also.
That's why in Gather, explain in detail. You have to tell one or two things more, because this contraception is for 3 months, this contraception is for 5 months, this is for 5 years. Explain them in detail. And second most important thing is, madam, recall, मैंने क्या बोला, मेरे को फिर के सुना. Then she should not say that you had not explained to me this. Whenever DMPA given, we say that you may become amenorrheic for 3 months. There may be intermenstrual bleeding. There may be postcoital bleeding. Okay. And sometimes you feel like pregnancy-like situation. Okay. Jaju madam, another case.
A 20-year-old primate with 10 weeks of gestation. She has history of dyspnea on exertion, and she has occasional epistaxis and hemoptysis for last 5 years. Her ECG, her echocardiography shows a non-restrictive perimembranous VSD and a balanced shunt and a significant pulmonary artery hypertension. Should we advise her MTP? Anyone who would like to take that question?
Now difficulty will increase.
Yes, first thing is we can't advise the MTP. If she wants the child, so it's her choice to have an MTP or not.
Madam, primary with VSD and PH.
Yeah.
So would you advise him that she should continue the pregnancy? Here not MTP. We are advising them whether she should continue the pregnancy or not.
So,
If she
sir,
continues, what are the risks? If she terminate, what are the risks?
And sir, in this case, we have to see both. We have to see the maternal risk as well as the fetal risk.
Yes.
She's already having a long history, 20 years old. What are the risks to the mother would be on the higher side. So we have to explain to her that because of the pregnancy, she can have heart failure, arrhythmias, maternal mortality will be on a higher side. So it has to be an informed choice to her. So what are the pros and cons of both, whether she should continue or she should not? So ideally, termination would be in favor of mother, would be a good option available to her. But then again, it has to be her choice.
We shall involve cardiologist, sir. We shall involve the cardiologist opinion.
Yes,
here.
yes, madam. But patient came to you, Sejal madam.
Yeah.
She is primary. She had not explained this thing to her maternal side. Husband is not knowing that she has got VSD, she has got PH, and they got married. Now she became pregnant. When she was non-pregnant, when she had came in adolescence, we had advised them to correct this congenital heart disease, then got for marriage. But now she got married. Within a 6 months, she became pregnant. And now she is coming to you because you had already seen her. Okay, so you know the case. They won't go to some another place. They will come to you only. And you are now here in a soup because she has got cardiac disease with pulmonary hypertension, VSD. So what we will involve everybody, but what is best for her that we have to decide. So that should be multidisciplinary
approach.
So we have to take cardiology
We
consultation.
should have detailed counseling regarding the risk involved for the maternal health in this case.
And
we
maybe
should also involve the
the
fetal medicine people also, because in her case, even the fetus is at risk. So we have to involve both. For the mother also, we need a cardiologist. For the fetal also, we need a fetal-maternal counselor.
Because baby will be IUGR because of the poor cardiac competence, there will be less blood supply. There will be hypoplacentosis.
Exactly. So we have to invite. We have to tell her both that apart from her, even the fetus has these problems. So then we can ask her to take a call.
Okay, now we had go send her to cardiologist. Now cardiologist says that your pregnancy is at risk. Now you have to go for medical termination of pregnancy. Okay. Now after 1 week, husband and wife both are came to you. Now, madam, mera MTP kar do.
So sir, it has to be done as soon as possible.
We have to take the
Earlier the best.
Yes.
Earlier the best.
Should do as soon as possible.
In the tertiary care center, we have to do.
Yes, in tertiary care.
We have to take a cardiologist opinion also. Fitness, cardiologically, basically fitness for the MTP.
We should do in a high risk center where all the
ICU and CCU are there.
Then for future pregnancy, now you all are expert. All my 10 batsmen.
We should advise her to go for the corrective surgery first.
Female cricket team.
Before she plans.
I'm the only male as a umpire because we have got all females in my team. So you have done very good things to her. Because all 10 are female.
So first should be the correction of her cardiac issues.
She
need to have a contraception at least for coming 3 to 4 years till she stabilizes. And
she
then
is ready
in
for
future,
pregnancy with least complication.
Yes.
So here she is prime. She has undergone MTP. Now which contraception?
Because she is 20, so she can still wait to conceive again.
Yeah, she can wait.
So in her case, we have to advisedly, if she goes for oral medication, then Prostagen only pills has to be given. Because with COCs, there are chances of thromboembolism, and she's already a heart patient. So in that case, everything which is based on implants, injections, and pills, but it has to be progesterone-only pills. Only methods.
Barrier methods are better, I think so. We can advise for the proper use of the barrier methods.
If they stick to it,
the infections also.
And then
having
other
side
things
effects.
like RPDs and Marinas, LNGs.
Yeah,
so
LNG
they'll work.
Sir, LNG would be a better
choice, yes.
Madam, with LNG, the periods will be decreased and she will have amenorrhea after 6 to 1 month, 1 year. 6 months to 1 year. She will be highly worried for that.
With proper counseling, we can.
Mirana, I think I don't think it's a good choice for her.
Ma'am, with the proper counseling, she can continue wearing the LNG IUD for at least 2-3 years, and there is a least failure rate with the LNG IUD.
Madam, she is very poor. She doesn't afford IUD.
If they strictly adhere to the barrier contraceptive method, that is the best. If they strictly adhere to it, otherwise progesterone only pills.
They will strictly adhere because husband knows that her wife is MD. You know her wife is MD, manufacturing defect. If he does something another.
Sir, everyone has some defect, sir. Everyone has some defect.
So now it is a big defect, na VSD with PAH. So now he will be very much secure that even I don't touch her. If I have to touch with barrier contraception. There should be barrier between me and her. Okay, so we have to take proper counseling. Where my second moderator, Madam Jaju, Madam?
Yes, sir.
Yes, Madam. Madam,
Madam is laughing.
So now you can explain what we should go for this type of patients, Madam.
So I have to say that no, she has to undergo a multidisciplinary approach, as rightly said by And it has to be a combined decision of all.
Hmm.
We have to give her all the choices of how things will be. If she continues the pregnancy, if she terminates the pregnancy, then she has to use a contraception. She has to correct her heart disease, and then she should plan for pregnancy. And the choice of contraception, as rightly said by everyone, progestin only pills or LNG IUS or barrier contraception, whatever she prefers. And she can again plan pregnancy after that.
After
And
correction
there
of
is a
our
big no for OC pills in this case.
big no. Because in this type of cases, we can have a more chances of thromboembolism.
Thromboembolism.
Okay, so recommended contraception, everybody access progesterone only. You see, ChatGPT also giving the same things. And this is all ChatGPT.
Now ChatGPT will be the future doctors.
No, madam, they are giving very good things. So we have to take the use of technology in our advantage. Gamma. This all the gamma effect. So permanent method is not good for her because she won't continue the pregnancy. Avoiding hormonal contraceptive pill because of the estrogen high risk. Considering choosing method, whatsoever she choose, she should adhere on that method. So safest option we have to give to don't have thromboembolism, and we have to inform them. So medical termination of pregnancy and contraception. Again, this is another case, madam. 7 weeks of pregnancy, normal delivery 1.5 years ago, but now patient has got asthma and patient is using pump. Okay. Again, we have to take history, which type of pump she is using, only steroid pump or only Lotaheller, only bronchodilator. Everybody agree that we have to control the asthma first and then we have to go for termination.
Yes, sir. So we can do simultaneously.
Yeah.
We can do both the things simultaneously. We can control the
How many
asthma
of you have got nebulizer in your hospital or OT room? Because in this type of situation, you must require nebulizer. Or if you don't have, ask from your friends and then go for this MPP. Otherwise, anesthetist say, there is no nebulizer. And madam, there will be very severe bronchoconstriction.
Yes, sir.
When with full IPPV, we are not able to dilate that patient because patient is using pump permanently and daily. So these all lungs alveoli are or steroid dependent. So we have to very much secure that we should do justice to this our patient. So we have to go for proper counseling. We have to take informed consent. Administer again. We can, because it is a 6-week pregnancy. Everybody agrees that we can go for
Medical termination.
Only thing in this type of patient we can't give, that is prostadine.
Prostadine.
Right.
Prostadine injection should be avoided for asthma because we have to be secure that whenever there is respiratory complication or patient has got respiratory disease, don't use prostadine. Otherwise, whenever there is severe bleeding, somebody try to use prostadine and that will again cause vasoconstriction or bronchoconstriction and we are in a soup. Now, what is your advice? Because we are talking about the contraception. What is your advice for her as a contraceptive method?
So same
Long-acting intrauterine device, maybe hormonal, non-hormonal.
POPs only, because estrogen is contraindicated, so you can use progesterone pills, you can use IUDs, either non-hormonal like copper or LNG, IUS, and the barrier method still is a good choice, but you should avoid combined hormonal contraception with caution. POPs are better, and if she opts for...
She has got delivery only after 1.5 years, one child, only one child she has got.
We have to use a permanent temporary method for her. Permanent method are not suitable for her.
Jaju madam, any advice for asthma patient for contraception?
Sir, if she's planning for a second child, then she will have to go for progestin only pills or IUDs. But
because
she
she
is okay,
is also giving lactation to her kids.
Dr. Ashish
so then we only go for progestin only pills.
Okay.
Estrogen containing pills are contraindicated in the lactation.
Okay, madam. So we have to give her POPs. Now there is a rapid fire. We have got 5-6 minutes only because we have to finish at 7 o'clock. Okay, madam?
Yes, sir.
Everybody, Dr. Monica.
Yes, sir.
Monica, madam, what are the choices of pregnancy with jaundice?
So contraception, we are not supposed to give estrogen preparation to her because they are going to affect the liver. Whatever drugs are hepatotoxic should not be given. Better to go for a LNG IUS or a copper IUS or the barrier methods.
So all the progesterone is safe if the patient is with jaundice, because progesterone is estrogen we shouldn't give. Jaju madam.
So next is epilepsy. And I think Jhalak Shah or Prema Nagar madam, is there?
We should advise for the IUD devices, non-hormonal, maybe hormonal. Progesterone only pills can also be given in this kind of patients. These are the three, or barrier contraceptives if they strictly adhere to it.
But in all this condition, we must see that all the epilepsy should be controlled very well. And
Yes.
it is not an emergency. We have to see that what are the anti-epileptic drugs they are taking. And
yes.
misoprostol
Which medicines are interacting with it.
And the drug interactions of the drugs with the
Yes, yes.
epilepsy.
Dr. Prema madam.
Yes, sir.
Yes. Patient with SLE, immunological disease.
So non-hormonal IUDs are the better option for them. But they can take progesterone only pills also, or that is a very safe option for them.
Patient with antiphospholipid antibody syndrome, increased risk of thromboembolism. So POP or IUD is best.
The best.
Chaju madam.
In case of GI diseases, such as inflammatory bowel disease, what type of contraception is indicated?
So, when we talk about MTPs, so in case of GI, MTPs, medical abortion, it is safe until unless there is no absorption problem. Surgical is absolutely safe. When we go for contraception, then copper-Ts and progesterone only methods are the best. It can go for implants, injections, and pills. Combination pills should not be given because there are chances of malabsorption.
Thank you, madam. What about the gynecological disease like patient has got some infection or patient has got endometriosis and she become pregnant? Now she doesn't want pregnancy. Which is your advice? That will correct both.
LNG IUD not in active infection.
For
but
infections, sir, barrier methods.
Better.
Their method and POPs are better.
Yes. Sir.
So hormonal preparations can also be given. They are also going to help in the endometriosis.
Yes, very good.
In case there is no running infection, sir. In case there is a running infection, then no copper-T, no LNGs. If there are no running infection, then LNGs can be given because they will help in endometrial reduction in endometrial growth also.
Madam, nowadays people are using Dynogest. This also give you very good amenorrhea because patient has got symptoms of endometriosis that also cover.
Covers in pills.
And if she wants to become pregnant, then now dydrogesterone is also good option. We can give dydrogesterone 30 milligram available in market. That will not hamper the ovulation. And if she become pregnant again, then it will nurture the pregnancy because this might be the pregnancy sometimes unwanted. And when she want pregnancy, we can give the option of Dynogest and dydrogesterone both. Jaju madam.
In case of HIV, Dr. Prajakta, what would be the contraception that would be advised?
I think
anyone who wants to take Dr. Pradnya, madam?
We can use the non-hormonal methods like copper IUDs are suitable. LNG IUS is again safe and effective, and we can use only POP methods are of choice. And we should avoid CSCs because if the patient is on antiretrovirals, it may give rise to drug infection.
Yeah, if husband is
thinking, can go for a barrier methods also.
Barrier methods are along with that we can use barrier method.
Barrier methods, anyway, we have to use it because when we are talking about HIV, irrespective of what other method she's using, she has to use
Madam, he has not used barrier method. That's why he become pregnant. She become pregnant. So we have to must counsel her that if you want to prevent yourself from getting HIV infection, start using barrier method. I have to go for MTP.
Exactly.
So if so many times we see that what is the contraception failure? Why she become pregnant? So one of the most important thing is non-usage of contraception. Contraception failed to use, make her pregnant. Or this is the only entertainment they have and they are utilizing it fully. So that's why they become pregnant. Okay, so we have to counsel them that you have to do this type of things, use barrier method. And if he is not agreeing, then we can use IUD and LNGs. Jaju madam, cancer. Who would like to take?
Who would like to take that question?
Yes, ma'am.
Sujata, madam?
Yes, unless we are very much sure that her serum beta HCG levels are normal, we should not advise her any contraception.
Post MTP, she has got 10,000 beta HCG.
Then we should not give her any hormonal contraception.
Okay.
We can go for IUD. We usually IUCD. We should wait actually till all the levels come down.
Because uterus is very fragile, very soft of uterus.
Yes.
So barrier methods can go.
Barrier
And if she wants to become pregnant again, then
it has to come down. The levels has to come down, and then she
beta
can.
HCG should be at the normal level for at least 3 months.
3
then
months.
we can advise her to become pregnant, and then otherwise there are so many chances. And then we have to see X-ray lung also for cannonball. We also see for thecal uterine cyst. Okay.
But if she's not got anything and then there is still endometrial hyperplasia, then we can advise her LNG IUS. It will act in both ways. It will also decrease the endometrial thickness and it will also act as a contraception for.
Yes, madam. Fantastic. So thank you very much, all my 10 women batsmen or batswomen for giving me opportunity, because men need difficulty because they are necessary to enjoy the success. So I am the only male in between the 10 and 11 beautiful women.
But you have played very well. You have made everyone knock out.
Very lively actually.
So otherwise, this is very boring topic of contraception and MTP, but we try to make it very useful. And I must thank so many pharma companies who are making dydrogesterone GIB of my paper. Out of 114 paper I had published. So at the end, everybody should be happy.
The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here.
Thank you very much.
Thank you, sir.
Giving me
Thank you, sir.
opportunity.
Thank you very
Public
much.
Awareness Committee, Foxy, Sejal, thank you for
Thank you, sir.
taking me in endoscopy
Thank you,
committee.
sir.
Thank you, Jaju madam, MTP committee person.
Thank you so much, sir.
Thank you, Monica madam.
Thank
you,
you,
our
Monica,
lovely
Dr.
Monica
Sejal,
madam.
Megha,
Manish sir,
Sanju,
and Dr.
Malak,
Monica for
Hema,
giving this opportunity.
Prajna, Prajakta, Sujata, and Jaju madam, and Monica madam for giving us opportunity. Thank you very much.
Thank
Thank
you,
you, Monica.
and Monica madam, everyone. Thank you so much, sir.
So thank you. We had come down at 7 o'clock. So at proper time, we had finished this. So I'm just
Definitely,
stop
sir.
sharing.
Now, one of the very few webinars of the Public Awareness Committee, which we have finished on time today. And I'm very happy to inform you that we have more than 300 delegates today online joined with us.
Okay.
Great.
I also would like to thank Dr. Madhvi Patel, madam, who has raised the occasion, Dr. Madhumika, for releasing the PAC times. I would like to thank both our faculties, Dr. Monica Singh, madam, and Dr. Ashish Pare, sir, for their excellent presentations. Our chairperson, Archana, madam, Rajbala, madam, Vedai, madam, and Rajran, sir, for being there for us. The panel discussion was the icing on the cake of this webinar. Dr. Manish sir and Dr. Rachna have kept us all alive in the discussion. Thank you so much, Dr. Madhulika ma'am, for being the expert for the panel discussion. I always extend my thanks to all the panelists for sharing your academic views on this topic. Thank you, Corona Remedies, for your technical help. And thank you, Abhishek, for all the help that you extend to us. Thank you, Monica madam.
Thank you, ma'am.
For being the convener of this series. Thank you, everybody. Good evening. Good night.
Thank you.
Good night. Bye.
Thank you. Namaskar. Bye.
Thank you. Thank you.
Bye.
Thank you, Raju madam, for co-moderating the session.
Thank you, sir.
Thank you so much, sir. It was a great pleasure to be with you.
Thank you, madam. Good night.
And thank you all panelists for such active inputs. Thank you so much.
Please
Thank
help
you so
and
much.
support me for
And
endoscopy.
thank you, Monica madam. You had
you,
done the
everyone.
walking and now
Monica.
came to the consulting room.
Monica, you're muted.
Hello.
Monica
now
madam,
you-
you have started your journey from
Yeah.
the garden and now you are in a consulting room.
Sir, I was in a corporation meeting, sir. From there, I came to the consulting.
Thank you, madam. Thank you.
Thank you, everyone. Please kindly help and support me.
Okay.
Sure,
All the best.
all the best, ma'am.
Thank you.